The following show is for educational purposes only. It is not intended to diagnose nor treat any medical condition. Any information or recommendations provided should always be discussed with your healthcare professional.
Welcome to the Patient Talks. I'm Physician Assistant Frank Smith. On this week's episode, we're going to be discussing rotator cuff disease. Today's episode is one, honestly, I had to do almost zero research on because I've been there. I've known the joys of rotator cuff disease. See if this sounds familiar to you. There's this deep, terrible ache nonstop in your shoulder. It won't quit. It won't let up. When you get ready to go to bed, you can get in about an hour's sleep, and before that pain gets even worse, it makes you get up and get out of that bed, and you try to just doze in a recliner all night. And then, just for giggles, if you turn that shoulder just right, it suddenly feels like a white-hot, rusty knife has been stabbed into your shoulder. So, yes, I know what rotator cuff disease feels like. You have my sympathies. I had the advantage of when I was dealing with it, I already knew the underlying anatomy of what was causing the problem. Today, we're going to cover what is rotator cuff disease, some of the treatments available, and long-term prognosis. As always, let's start with some basic anatomy so we understand the underlying process. So an elbow or a knee is pretty straightforward. That's just a hinge joint, right? Meanwhile, the hip is a ball and socket joint where the top of the femur becomes just a perfectly round ball and it fits inside the bony socket of the hip, and that's what allows your hip to do this. The shoulder is a little different. The top of the humerus is shaped just like the top of a femur. It's this perfectly round ball. But instead of it fitting inside a true bony socket, there's just a cup of bone that it sits in. It's called the glenoid fossa or the glenoid cavity. But it's just this little cup that bone of the top of the humerus sits in. The rest of that joint is made up of 4 different tendons that come across to fill in the rest of that joint, and we call those the rotator cuff. The most common one that gets injured is the one called the supraspinatus, and its job is to hold the humerus into that glenoid fossa when we start to raise our arm. So I want you to imagine I'm sitting here with a cup. I start to raise my arm. If there's nothing to hold it in place, it will start to climb out, right? So the supraspinatus comes across, and as we start to rotate, it holds that humerus in place, allowing us to go up. The supraspinatus is the most common tendon that's injured in rotator cuff disease. Some of the others can be injured, but that tends to be a traumatic injury. So baseball players, car wrecks, that sort of thing. Supraspinatus is usually a chronic injury that happens to that tendon. As far as what caused it, coming across here is your clavicle, your collarbone. If you feel over to the side, you'll feel a little bump, and then you'll feel the collarbone extend out. Actually, at that point, you're at another bone called the acromion. It's what comes off around the shoulder blade and fills in. The supraspinatus goes directly up under it. And in some people, that acromion rides a little low. And so the supraspinatus tendon ends up kind of grinding across that acromion, and over time it starts to fray just like a rope. Some of the things that make it more likely to happen is if you do a lot of overhead work, so people who like paint ceilings, carpenters, that sort of thing, this is a common one you see. It's also fairly common as you get a little bit more mature, to be honest. My own mother has had to deal with it, and she was kind enough to pass those genetics on to me. Treatment for it, a lot of times we'll start with placing an injection into the shoulder to help to reduce the inflammation to that area. Anti-inflammatories are well worth doing. I did find that lidoderm, lidocaine patches were helpful. Heat, cold, back and forth does help as well. But to be honest, the main treatment for that fraying supraspinatus tendon is physical therapy, and it flat works. But let me tell you, they're going to hurt you. And let me say it again, they're going to hurt you. I had no idea, and I practiced medicine, how much they were going to get my attention in physical therapy. but at the end of it. So you have this brief period of time where they're making you very uncomfortable, but you'll notice later that day that shoulder's not as bad as it was before, and it slowly continues to improve with the work that they do. Some patients, unfortunately, don't really respond to physical therapy, though the vast majority do. If you're not getting any response to injections, if you're not getting any response to the heat and the cold and the lidoderm patches and physical therapy, at that point we may be looking at surgery. But most of the time on a simple fraying supraspinatus tendon, physical therapy will take care of the problem. Now, if you have a complete tear, there's one option, and that's surgery. As far as the surgical options available, I'm going to leave that to your surgeon to discuss. But for the vast majority of chronic supraspinatus, physical therapy is the hallmark of treatment. There are some exercises that you can start doing at home before you have a chance to see the physical therapist that can help. Be sure to check a reputable website. I do recommend UpToDate.com is one that is commonly used. Medscape isn't bad. You can never go wrong with one of the big hospital corporations that have their websites as well. Some of the exercises they will discuss, they'll talk about wall crawlers. They have front wall crawlers, side wall crawlers, and there's one that you flip a towel behind your shoulder to help stretch it as well. Those are worth doing. I will tell you that what I found worked best when I'm doing those exercises was to heat that shoulder up good and proper first, usually with a heating pad, do the exercises, and immediately after getting done, ice that thing down, okay? There is one I do want to bring up because some physical therapists frankly forget to mention this to their patient. When you complete physical therapy, your shoulder will be a lot better. However, you're not done and you're never done. There's a few of the exercises that physical therapy will have you doing. You need to get in the habit of doing those a couple of times a week forever. I was lucky enough that when I went through physical therapy, my physical therapist told me, she said, "You're good. Here's a couple of exercises for you to do. You do these a couple of times a week and you will never have to come see me. You let life get in the way, and in about 3-4 months, that shoulder will start to sing to you. If you keep ignoring it, give it about a year and you're right back in here." And frankly, I never want to see her again. So I have stayed on top of those exercises. So that's it. That's the very basics of rotator cuff disease. I hope you've learned a lot. I hope it's been entertaining. If either one of those is true, please click the like and subscribe button. Next week, I'm going to be bringing out a new recurring feature. I'm calling this one Behind the Stethoscope. It's going to give you some insight to our side of medicine, so I hope you come back to watch that. Until then, get better and make me look good. See you next week.